This video will focus on persistent sleep-wake disturbances and persistent fatigue. The information has been provided by the Ontario Neurotrauma Foundation's Best Practice Guidelines for Concussions and Mild Traumatic Brain Injuries. In the immediate acute stage following an injury, there may be an increased need for sleep. This tends to decrease over time, with insomnia being the most common form of sleep disturbance reported in both the subacute and chronic stages of an injury. In addition to insomnia, more than 50% of patients report sleep disturbances. As such, patients should be educated and reassured about the fact that sleep alterations are very common within the acute stage. Other notable sleep disturbances include hypersomnia, obstructive sleep apnea, poor sleep maintenance, poor sleep efficiency, early awakening, delayed sleep onset, or other alterations within the circadian cycle. It is important to note that similar to other persistent symptoms following a concussion or mild traumatic brain injury, sleep disturbances can be secondary to other conditions, such as depression, anxiety, post-traumatic stress disorder, or pain. As such, a key feature of diagnosis is obtaining a history from the patient to rule out pre-existing sleep disorders and document symptoms after the injury. Qualified healthcare professionals should screen for the following as they may influence the sleep-wake cycle: pre-existing sleep disturbances and disorders, medical conditions, current medication use, comorbid psychopathology, and risk factors for sleep disturbances. A more detailed list of the above factors can be found in Table 7.1 linked below this video. Once a thorough evaluation has been conducted, treatment of sleep disorders within the mild traumatic brain injury population may take the form of both non-pharmacologic and pharmacologic methods. Patients who have identified sleep alterations should be monitored for sleep-wake disturbances, while those who have persisting sleep disturbances should be monitored for sleep-wake disorders such as insomnia. Appendices 7.2 and 7.3 may be used to help the clinician identify these conditions and are linked below this video. Additionally, Algorithm 7.1 outlines key steps for the assessment and management of persistent sleep-wake disturbances following an injury. For treatment of insomnia, cognitive behavioral therapy has been established as the treatment of choice. A referral to a professional with training in CBT is ideal. CBT is recommended as it addresses the factors that perpetuate insomnia. Such factors include sleep hygiene, maladaptive sleep habits, autonomic and cognitive arousal, and dysfunctional beliefs and attitudes towards sleep. While waiting for CBT for insomnia with a professional, or if this treatment is not available, behavioral recommendations can still be implemented by a primary care provider. See Appendix 7.5 for more information. Other non-pharmacologic treatment options that have been found to be useful in the treatment of insomnia include melatonin taken 2 hours before bedtime in conjunction with reduced evening light exposure and light therapy in the morning, magnesium and zinc supplementation, and acupuncture and mindfulness-based stress reduction therapy. When pharmacologic interventions are used, the aim is to establish a more routine sleep-wake pattern using agents with minimal risk of dependency and adverse effects. When prescribing medications, the patient should be advised not to drive after taking the medication, and it is recommended that they not have to be somewhere early the next day. Alcohol should not be taken in conjunction with the medications. The use of modafinil and armodafinil can be considered in patients with excessive daytime sleepiness. In addition to sleep disturbances, fatigue is one of the most pervasive symptoms following a concussion or mild traumatic brain injury. Fatigue can affect physical, cognitive, motivational, and psychological spheres. It has also been found to have a significant impact on well-being and quality of life following an injury. Due to the prevalence of fatigue and its effects, it is recommended that all patients be assessed for fatigue through a focus history and relevant items from administered questionnaires. Such questionnaires to aid in this assessment are as followed and are linked below this video. Further information on factors to consider during assessment and management can be found in Table 11.1 linked below this video. Fatigue can be persistent and has been shown to still be present up to 5 years post-injury. Those who experience fatigue at 3 months post-injury are increasingly likely to continue to experience fatigue beyond 6 months post-injury. As persistent fatigue may cause other symptoms to worsen, early intervention is required in order to prevent interference with the patient's ability to participate in rehabilitation therapies. If identified as a significant symptom, some key considerations that may aid in the management can include aiming for a gradual increase in activity levels that will parallel improvement in energy levels, including exercising below symptom threshold, reinforce strategies of cognitive and physical activity pacing and fragmentation across the day to help patients achieve more without exceeding tolerance levels, encouraging good sleep hygiene, especially regularity of sleep-wake schedules and avoidance of stimulants and alcohol, and proper relaxation times, providing patients with a pamphlet containing advice on coping strategies for fatigue, acknowledging that fatigue can be exacerbated by low mood or stress, and using a notebook or a diary to plan meaningful goals, record activity achievement, and identify patterns of fatigue. For further information regarding sleep-wake disturbances and fatigue, you can refer to Sections 7 and 11 of the Ontario Neurotrauma Foundation's Guidelines for Concussions and Mild Traumatic Brain Injuries and Their Persistent Symptoms. Special acknowledgements go out to the Kinesiology Department at the University of Waterloo, the Centre for Community, Clinical and Applied Research, and the Ontario Neurotrauma Foundation, which provided the funding for this video.